So the second theme I'd like to address is the different therapies which are addressing the clinical manifestation. You talked about thrombosis because it's particularly in patients with polycythemia vera, it's a considerable source of the morbidity and also some mortality. And there is obviously, if we had therapies which can alter the disease natural history and impact the clinical characteristics such as the thrombosis and so on, that would be the ideal thing. So in polycythemia vera, it's interesting when you look at the data of interferons. So the alpha interferons, of course, have been around for forever. I mean, they've been around for at least 5 decades. I remember 3 decades ago, my first book, which I wrote in hematological malignancy, was focusing on interferon. But of course, most of the community was very concerned about side effects of interferon, but they were not life-threatening side effects, but they were major side effects which affected the quality of life. So most patients would get very tired and flu-like symptoms and so on, and they will continue. But now over the last 15 years or a little bit more, we've had the longer-acting interferon, and people have been fine-tuning the molecule very nicely, including using the machine learning technologies to try to focus on the efficacy aspect and dampen down the toxicity aspect. So there are numerous formulations which have been tested. And in polycythemia vera, there's one particular formulation which is now approved by the FDA, and it's also approved in a number of other countries. And that's the long-acting interferon, which is called Ropeginterferon. The full name is a bit of a mouthful: Ropeginterferon alfa-2b NJFT. It's produced by a very, very well-established company in Taiwan, in Taipei. And so they've completed a number of studies, phase 2 and phase 3 randomized studies. And a couple of the studies were presented with their more mature follow-up. And it's very clear that a patient with the intermediate risk polycythemia vera and the high risk, they do get benefit. The transfusion requirements are reduced. The thrombotic episodes which these patients get are also reduced. But more importantly, it seemed to affect the allelic burden of the JAK2 V617F mutation, which drives 98% of these patients. So the first question which comes up is that, okay, if you're reducing the JAK2 allelic burden, does that mean that you are actually doing something to the molecular driver which is leading to the disease, or is it just something which is happening biochemically, perhaps, And there is some debate there now, because the polycythemia vera, of course, is well characterized from the histology or hematopathology. In fact, the two classifications we have to diagnose a polycythemia vera, as all the other MPN, are either the WHO classification or the ICC, the International Consensus Group classification. And by the way, these were also presented and debated at some length during the Congress. And so they rely on a number of characteristics, major and minor, and the hematopathology plays a pivotal role here. So if you have the allelic burden reduction and you're improving the hematopathology constellation of finding, that is a reasonable indication that you are actually changing the natural history of the disease. And it seems that is happening, not in all patients who respond, but in a sizable number of patients. And I think the next year or two are going to be critical, because the patients who are responding are being followed, and they've been having these tests on a serial basis, longitudinal. So you're monitoring these patients. So we should be able to know. The long and the short is that there is hope for patients with polycythemia vera, that even for the low risk, that we probably should have a therapy available for most patients, which could modify their disease. And then those lessons which we'll learn can then be applied to a disease like myelofibrosis, where thrombosis is also a major problem, and perhaps less so with essential thrombocythemia.